someone had a question, why not the full spine? So is that something that, in what situation would you recommend that?
Yeah, I tend to make my surgical decisions based on whether or not there's a cervical syrinx, and that's just based on our data when we looked at syringomyelia with Chiari malformation. The really strong cause and effect correlation that we were able to draw statistically were the large cervical syrinxes. So if someone has a small thoracic syrinx, I personally do not view that as a reason to operate. I might operate on that person for another reason. Perhaps they have Chiari headaches, or they have other compelling symptoms that would cause me to want to operate on them. But if the person is not a surgical candidate because, say, they're asymptomatic, then having a small thoracic syrinx does not, for me in my practice, cause me to want to operate on that person. There's just frankly not a statistically proven strong cause and effect relationship between small thoracic syrinxes and Chiari. There's a really good, well-established statistical relationship between big cervical syrinxes and Chiari. There was a paper published about 20 years ago now pointing out that if you don't get complete spine imaging, you're going to miss some syrinxes. And that's true. There's no question about it. The question that I have, though, is do I actually make a different decision for that patient if I know about the small thoracic syrinx? And for me, the answer has become, based on our cause and effect conclusions, the data that we have, no. So I'll look at it if it's there, but if they don't have it, I don't send them back for it.
Okay. So what happens in the case of, say, there's a lumbar syrinx and someone has a Chiari decompression and it just goes away after surgery? Is there any kind of reason that would happen? What's the rationale?
No, I mean, it's nice if that happens, but again, I don't think there's any statistical basis for making a decision on that basis.
Okay.
So, lumbar syrinx. So just to follow up on that, lumbar syrinxes are much more likely to be associated with tethered cord, either that or just what we call a terminal syrinx, which is just kind of a benign finding that people have. They tend to be asymptomatic. But if somebody has a lumbar syrinx, I'd be very interested in studying them for a tethered cord, not so much for Chiari. In general, that's true for syringomyelia pathophysiology. If you just look at syrinxes anywhere in the cord, and Rick Batzdorf has always been a big advocate of this, the so-called idiopathic syrinxes that we don't know why people have it. Often you can find a CSF flow obstruction somewhere just above where the syrinx starts, like an arachnoid cyst or arachnoid banding or something like that. And that's true for Chiari as well. In general, the ones that we feel really confident that we know that Chiari is causing the syrinx tend to be pretty close to the Chiari.
Okay. So cerebellar position is one measurement. Are there any other measurements that you would make to kind of correlate with some clinical symptoms?
Well, we've tried very hard to do that with a lot of studies, and right now the answer is we can't validate anything else that matters. And other groups that said they've come up with it, again, you can't validate what they've done in a secondary group either. So I'd love to be able to answer that affirmatively, but there's no evidentiary basis for doing that right now. Now, if you're going to operate, though, there are some other things that we know matter with respect to what kind of operation you're going to do. So you look at the dens and whether it's retroflexed. You look at the clival angle to see if there's any evidence for any kind of skull collapse or anything like that. So you want to look at lots of features of the MRI if you're operating, but not necessarily with the decision about whether you should operate.
Okay. So would you say that the decision to make that surgical intervention is really based on symptoms, or how do you really do that?
It's symptoms and the presence or absence of a cervical syrinx for me. So if you have a large cervical syrinx, in general, we advocate for surgery, even prophylactic surgery in an asymptomatic person. If you have no syrinx, then it's all about your symptoms, and it's a quality of life operation, essentially. We talk about whether your symptoms correlate with the Chiari, whether it's most commonly headache. So we go through the checklist and features of a headache and try to sort out how likely is it that your headache is from the Chiari. and it's virtually never 100% and it's never zero. It's always, somewhere in between. But we're much more likely to offer surgery if we think that it's very likely to be from the Chiari based on the features. And the other very, very important part of that is, okay, let's say we say it's from the Chiari, how much is it affecting that person's quality of life? So I might see a patient that has an incredible headache problem, but their headaches last for 4 hours and is associated with vomiting, and they see, flashes of lights in front of their eyes, and well, they have migraines. So we're not going to offer surgery, at least not for that symptom, because we're not going to fix a migraine headache with Chiari surgery. The converse of that situation is we have patients sometimes that will see us and they have a Chiari, and we'll go through their headache features, and they have a headache in the back of their head, and every time they cough and sneeze, it comes on and it lasts a few minutes and it goes away. And it's 100% a Chiari headache, where we feel very confident we can fix that with surgery. And they'll say, oh yeah, but I don't want brain surgery. It doesn't really bother me at all. I mean, I have a great life and I get this thing once a month, so who cares? So for that patient, surgery is not necessarily a good idea either, because it's a quality of life operation. And if your quality of life is excellent and you're not bothered with symptoms, then why would you do it? So really, for the headache surgery, if we're doing a Chiari surgery for a headache, they need to kind of check both boxes for me. Like, is it likely to be from the Chiari? And if so, does it bother them enough to justify having brain surgery?
Right. Yeah, it's a big decision.
Yeah.
To that end,